Good afternoon, our dear students. I'm glad to see you in my YouTube channel and in our department, which named Propaedeutics of Internal Medicine and Physical Rehabilitation Department. This lecture, it is the first lecture for students of third year MM groups. And today you have a first lecture in discipline Propaedeutics of Internal Medicine. And on our today's lecture, we're going to give a definition what is internal medicine in general, why propaedeutics it is an introduction to clinic of internal medicine. We will discuss basic concept. We will talk a little about medical ethics and deontology in the clinic of internal medicine, which is the necessary part of all communication with the patient and all working in internal medicine. The general approach to the patient, what is interviewing, what is objective examination of the patient, instrumental and laboratory methods of evaluating of the patient status. All information will be in general and further during our year. System by system, we will discuss more information about interviewing, objective examination of patient, additional lab and instrumental tests for each system, each syndrome, each disease. And today, in general, we're going to discuss what is internal medicine, what you will learn on this cycle, basic concept, basic definitions in it, and in general what is methods of investigation of patient and approach to the patient is available for us. And before we start, shortly about rules in our in my lectures. All lectures of this semester will be on my YouTube channel in streams according to your schedule. According to your timetable, in time it will be start. You can listen it. I leave all streams recording on my channel. If further you will need some information to preparing for practical class, to return, maybe prepare to some final works, you should you can see it one more time. They all saved on YouTube channel. And after each lecture, I ask all students who listen in me, leave in comments your name and number of group, because we control attendance of lectures. Let's start our today's work. First of all, let's give a definition what is internal medicine. Internal medicine, it is a medical specialty dedicated to the diagnosis and medical treatment of adults. A physician who specializes in internal medicine is referred to as an internist. Subspecialties of internal medicine include cardiology, that learned heart and vessel disease, endocrinology, hormone disorders, hematology, blood disorders, infection disease, gastroenterology, diseases of gut, nephrology, kidney diseases, oncology, that learned cancer, pulmonology, lung disorders, and rheumatology, that evaluate arthritis and musculoskeletal disorders. All these subspecialties, except of infection disease, you have a separate discipline, and oncology, you have separate discipline too. All others you will learn in your internal medicine classes. What is propaedeutics? What is why we use this unusual word? It is a historical term for introductory course into the art or to the science. Short history of the development of internal medicine as a specific discipline begins at Thomas Sydenham's concept of disease, articulated in the 17th century. Sydenham closely observed clinical phenomena at the patient's bedside and conceived to the first time the possibility of variety of distinct diseases, and opposed to general illness caused by imbalance of humors, which was the prevailing theory of disease causation. Sydenham's work created a framework of the classification of diseases which was built upon the François Boissier de Savage, who in 1763 published the first medical nosology or description of disease symptoms. Savage's emphasized symptomatology as the basis of disease classification since there was no information then available about causes of disease. From the time of Savage until the 20th century, internists could do little to treat disease. Unlike surgeons who could remove offending organ, internist has no specific therapies. Most of the treatments that physician could offer made of patients worse, not better. The issue of internist's skill was the accuracy of his diagnosis and reliability of his advice about probable outcome of disease. Only with the development of disease-specific therapies at the beginning of 20th century did internal medicine become effective in the cure, rather than just the supportive care of patients. As more the specific medications and courses therapy become available, the volume of medical knowledge increased. More and more subspecialties devoted to particular organ systems split off, leaving internal medicine as the specialty of physicians dealing with all problems of the adult patient. Let's discuss basic concepts that we use in internal medicine, and let's start from the beginning, the whole beginning. First of all, what is health and what is disease? Health, it is a state of physical, mental, and social well-being in which disease and infirmity are absent. Disease, it is a particular abnormal condition that negatively affects the structure or function of all part of the organisms, and that not due to any immediate external injury. Diseases are often known to be medical conditions that are associated with specific symptoms and signs. Diagnostic. What is diagnostic? It is a science of methods by which disease is identified. A diagnostic consists of clinical examination of patient and diagnosis basing. Diagnosis, it is a short conclusion of a doctor about the essence of disease and patient's condition expressed in terms of modern medical science and resulted from the examination of patient. Preliminary diagnosis is based on the patient's present complaints, history of present disease that we name in Latin anamnesis morbi, the past history anamnesis vitae, and physical examination. Data inspection, palpation, percussion, and auscultation. Clinical diagnosis is based on the subjective examination of patient, like injury, complaints, anamnesis morbi, and vitae. And objective examination, physical, instrumental, and laboratory. Final diagnosis is based on the subjective examination and treatment. Diagnosis has the following structure. First, it is a main disease. Second, it is complication of main disease. And third, it is concomitant concurring disease. Symptom is a sign of disease and pathological changes in the patient organisms. Symptoms can be subjective symptoms, are those that can't be found on examination of the patient. And the opposite, objective symptoms, are those that can be found in examination of patient. And more of it, we can divide symptoms not just subjective and objective by pathological, compensatory, early or late, specific or non-specific, favorable or unfavorable. Syndrome. What is syndrome? It is defined as a combination of symptoms that are interrelated and give rise to one another. And another term, it is syndrome more complex. It is defined as symptoms that are not interrelated, do not give rise to one another. And let's talk a little about ethics and deontology. Deontology, it is a professional ethics of medical workers and principles of behavior and medical personnel directed toward maximum benefit of treatment. Medical ethics, it is a study of moral values and judgments, and they apply to the medicine. Main ethical principles include beneficence and non-maleficence, autonomy and consent, truth-telling, confidentially, preservation of life, and justice. Beneficence, it is the act of doing good, while not maleficence, it is act of non-doing bad. In practical terms, medical practitioners have an ethical responsibility to strive and do what is in the best interest of their patients. However, it is important to remember that some medical interventions may seem beneficial, but may also carry with them the possibility of causing harm. In fact, nearly all medical treatments and procedures could be argued harm of the patient in some way, but it is more than due with the magnitude of benefits versus the magnitude of potential risks. What is autonomy and consent? Autonomy is a right of patient to make an informed, uncoerced decision about their own health management. In this principle is disregarded by a medical professional because he or she believes another decision would be better to the patient, then it is termed paternalism. The autonomous decision should never be overruled by a medical professional, but not all decisions are autonomous. For patients to have autonomy, they must have a capacity to receive, retain, and repeat information that is given to them, provided the information is complete and given to them in a manner that they can understand. Consent, in extension of autonomy, and has many types. Implied consent, when doctor assumes that certain actions or body language from patients imply that the patient has consented to the planned action of the doctor. Expressed oral consent is when the patient has verbally given to doctor permission to proceed with the intended action. Expressed written consent, it is documented evidence that the patient has, usually with signature, given consent to a procedure. Written consent should be only obtained after oral consent. Fully informed consent is consent given by after being given all the information about the procedure. When possible, fully informed consent, both written and oral, should be obtained before any procedure, examination, or treatment. The ethical principle truth-telling is the process in which doctor gives a patient all known information about their health. It allows the patient to be fully informed and therefore allows the ethical principles of autonomy and consent. A point of note that always needs to be considered is the fact that some patients do not want the information. Therefore, it is important to ask the patient if they want to know or not. The only other extremely rare occasion when it is acceptable not to tell patient the truth is when patients may come to harm when being told, if you tell me I have cancer, I will kill myself. It is a direct damage to their life. Next principle, it is confidentiality. The ethical principle of confidentiality ensures that the medical information held about patient is acceptable only to those for whom the patient has given via autonomous and full informed consent. In order to achieve trust between medical professionals and their patients, confidentiality must be maintained. Confidentiality may be broken if information shared by the patients refers to the potential danger to public safety, or if it is ordered by a court. The ethical principle of preservation of life is will to treat the patient illness with the aim of prolonging life. After all, most patients want to live longer. Most doctors may have joined profession to save lives. This principle may have overruled if the patient has made a living while stating their desire not be resuscitated. Justice. Justice refers to a distribution of things and position of people within society. In a medical setting, justice involves the allocation of healthcare resources in a fair way. This may be an equal distribution of a maximization of the total or average welfare across the whole society. And next part of our today's lecture, we will talk a little about approach to the patient and interviewing. As for me, it is the most interesting part. I want to give you a little bit more information, but it will be not a scientific, not a direct diagnostic information, but it is information for you for understanding why it is important and why you should learn it and why you should pay such a lot of attention in our classes to the part of interviewing. The medical interview is practicing physicians' most versatile diagnostic and therapeutic tool. However, interviewing is also one of the most difficult clinical skills to master, and demands made on the physician are both intellectual and emotional. The analytical skills of diagnostic reasoning must be balanced with the interpersonal skills needed to establish rapport with the patient and facilitate communication. Interviewing is often considered part of art in contrast to the science of medicine. There are many reasons to dispute this distinction. Perhaps the most compelling that labeling in an art removes interviewing from the realm of critical appraisal and suggests that it is something magical or mysterious about interviewing that can't be described or taught. This chapter will demonstrate the validity of interviewing as a clinical science based on critical observation and analysis of the patient without diminishing its excitement and clinical activity. It provides a guide to conducting initial interviews and making sense of what happens. It will outline the knowledge, attitudes, and skills that lead to effective interviewing. The discussion will focus on the problem-oriented diagnostic interview, but the health promotion interview and interviews during follow-up visit will also be mentioned. Most clinicians rate of patients' medical history as having greater diagnostic value than either the physical examination or result of laboratory investigations. The clinical adage that about 2/3 of diagnostics can be made on the basis of history alone has retained its validity despite on the technological advances of the modern hospital. An accurate history also provides focus of medical examination, making it more productive and time efficient. Clinical hypotheses generated during the interview provide the basis of cost-effective utilization of the clinical laboratory and other diagnostic modalities. A diagnostic utility of the interview is complemented by its therapeutic power, as the medium through which the positive relationship is established between the doctor and the patient. Empathic, patient-centered interview can bolster and patient's sense of self-esteem and lessen the feelings of helplessness that often accompany an episode of illness. The therapeutic alliance forged during the clinical encounter provides the foundation for ongoing patient care and education. Fundamentally, the medical interview is a purposeful conversation undertaken with a set of goals and priorities clearly maintained in the physical mind. Its direction reflects the respective needs of both participants, patient and physician. The patient enters an interview seeking relief from the discomfort and uncertainty of illness, while the physician actively conducts the interview in order to clarify the patient's problems and derive diagnostic and therapeutic plans for the patient's benefit. During the interview, the patients need to have his or her story, head of suffering understood, is balanced by the physician's need to know and understand as much as possible about the patient of his or her problem. Medical interview are two of basic types: the problem-oriented and health promotion interviews. The goals of problem-oriented interview reflect the patient's request for help and specific problems. The health promotion interview establishes a data baseline concerning the patient's current and past health problem. Assesses current health risk factors like smoking, diet, alcohol consumption, heritable disease in the family, and can detect early evidence of disease change in bowel habits, weight loss, chest discomfort. What the patient did not consider severe enough to warrant the problem-specific visit to doctor. In reality, most medical encounters combine the problem-oriented and health promotion approaches. Issues of health promotion are important to all patients, and patients who come to the doctor for a routine check-up may have hidden concerns about specific symptoms. In fact, careful questioning about why and when the patient schedules a routine check-up often uncovers significant health concerns. The medical interview provides two categories of information unavailable from any other source: what the patient says about the illness and how it is said. What the patient tells the physician provides the factual content, the medical history. The factual content is the physician edits and records and written record the medical history. It should include a comprehensive chronological report of patient's illness with enough information, both positive and negative, for accurate, inclusive diagnostic reasoning regarding possible etiologies and the patient's problems. The process of the interviews that can actually happen between physician and patient during the encounter. Observation of process, both verbal and non-verbal, provides important information about the patient as a person. Through the patient behavior during the interview, like facial expression, posture, gestures, he or she communicates emotional concept, reactions to illness, and style of relating to others. Sudden shifts of topic, avoidance of certain issues, and the flow of spontaneous associated may point to concepts that are not expressed directly. The physician's communication style and behavior during the interview and is also the critical element of interviewing process. The distinction between the content and process highlights and dual skills required in the medical interview: analytic and interpersonal. Although these skills can be discussed separately, they must be practiced together. The clarity and validity of information gathered during the interview, its content may be critically determined by the quality of relationship that developed between patient and physician, its process. A candid disclosure of patient consent is most likely to come about the context and non-judgmental interviewing style. A final comment on process and content may be helpful to the beginning students. The content and organization of the written medical history is often confused with the process by which the clinician actually collects information during the interview. The written medical history is actually a journalistic endeavor in which the clinician edits and organizes the patient's spontaneous report into a formal, organized presentation. The final product is a medical chart by may bear little resemblance to the work the clinician performs the bedside. Patients rarely report their symptoms as an organized and logic fashion comparable to the description of disease in medical texts. In fact, patients complain of illness, sickness, rather than stating their problems in terms of pathophysiologic categories of disease. Students who expect their patients to present classic symptoms, complexes, and organized fashion experience considerable frustration and may become rapidly disillusionized with clinical medicine. The complaint that the patient was poor historian may reflect unrealistic expectation on the interviewer's part. The clinical practice, the interview is collaborative effort between the physician and patient. Such scientists like Reiser in year 1980 states that physician, no matter how skilled, can't simply extract the history from his patient. The patient, no matter how articulate, cannot give history in final form without help and guidance from the physician. To say that we take a history from the patient implies that the story of illness can be extracted from the patient like shaking coin from the piggy bank. This erroneous conception of the medical interview leads to frustrated attempts of shaking out the history as if the patient was willfully keeping this valuable coin hidden. What about therapeutic tasks? The help in relation to consent stone and medical history, the practice of medicine, medical interview practice, important avenue to establish and help in relationship build on trust and commitment. This does not occur magically. The physician actively employs interviewing techniques to promote their relationship. Non-judgmental interest to the patient's problems like active listening, empathy communicated to the patient, and accurate assessment of emotional state, and concern to the patient to unique person are among the most important tools of the physician interpersonal repertoire. These techniques not only strengthen the therapeutic bond, they improve the interview's diagnostic power by providing the patient with an attentive and receptive audience. By helping the patient describe the sort of out experience, the physician can provide explanations and meaning to events, the feeling that we formerly perplexing and threatening. The patient's sense of control can be re-established and in a realistic fashion, and feelings of helplessness and hopelessness can be addressed to the context of helping relationship. Problems can be reframed and prioritized to help patient develop his or her own solutions. Obviously, the goals of medical interview has much in common with psychotherapy. Furthermore, patients who sense and their history taken seriously may feel encouraged to become more active participants in their medical care. Patient complaints and cooperation with future diagnostic and therapeutic plans often hinge on the physician's skill and development of negotiated and management plan that encourages patient involvement and initiative. A method a physician uses to establish rapport differs from each interview. Each encounter is unique. One patient may respond best reassuring touch, one to a well-timed interpretation of emotional concept, another to a moment of shared silence. Observation of the patient responses serve as a physician's guide in which techniques to employ and provides feedback about when and how to change course. Patients demonstrate a remarkable variety of responses to a medical interview reflecting to the range of human personality type and responses to illness. Anger, anxiety, denial, vagueness about detail, emotional embellishment, and unreasonable expectation or demand are but a few of the difficult but common challenges in the medical interview. And about objective examination of patient. Physical examination is a process of evaluating objective anatomic finding through the use of observation, palpation, percussion, and auscultation. The information obtained must be thoughtfully integrated to the patient's history and pathophysiology. Moreover, it is a unique situation in which both patient and physician understand that his interaction is intended to be diagnostic and therapeutic. The physical examination, thoughtfully performed, should yield 20% of the data necessary for patient diagnosis and management. It is objective 2. The material. The single most useful device for optimal performance of the physical exam is inquisitive and sensitive mind. Next most useful mastery of techniques of observation, palpation, percussion, and auscultation. Less important are the tools required for examination. Here you see in this table. Usually we need a cotton wisp, flashlight, lubricant jelly, mydriatic solution, ophthalmoscope, paper towels, pocket eye chart, rectal gloves, reflex hammer, wheels of coffee or cinnamon, a tuning fork, tongue depression, tissues, thermometer, tape measure, stethoscope, and sphygmomanometer. The environment affects the quality of physical examination. It is in wise arranged to quiet and privacy, darkening the room for parts of examination and comfort of the patient and examiner. The complete examination should proceed the orderly fashion with a minimum of required position shift by the patient. On the other hand, the physician must be able to ascertain to integrity of the various organ systems from regional examinations. For instance, from examination of the head and neck, and physician must identify the vascular, neurologic, lymphatic, skeletal, and integumentary components and must relate them to components of their other body regions. It would be tedious, by contrast, to examine the vascular system in its entirety, followed by complete neurologic examination and other organ system, each in turn. When examining the anatomic region, the observer must be alert to the appearance of any abnormalities and question in the type of morphologic aspect of the abnormality and its clinical significance. And here you see a table with the body position. You can make screen for yourself the recommended position of patient and examiner during physical examination. The general physical examination can take many forms depending upon circumstances. Most often the examiner evaluates body regions as general way, looking for abnormalities. Clues derived from the history signal the need from the more precise and detailed examination of a given system. A thorough physical examination often includes a sequence presented in table. Here you see steps of physical examination. Yes, I can make screen too. And it starts from the patient comfort after it optimal environment, and checking of vital signs and general inspection, inspection of head with checking eyes, ears, auto-ophthalmoscopy, nose, mouth, face, neck, anterior torso, posterior torso, completion of sitting portion of the examination with the patient supine. We check thorax, abdomen, proximal lower extremities with the patient standing. We check external genitalia, pelvic and rectal examination. The clinically significant physical examination is a flexible entity that should vary with needs of the patient. Periodic examination for health assessment need to be comprehensive, as do most hospital admission examinations. In contrast, it will not be cost-effective to undertake a complete physical examination in most patients presenting with the symptoms of an upper respiratory tract infection or urinary tract infection. Because the large degree of variability of observing many physician signs, the following recommendation can be made when reporting and interpreting physical findings. Emphasis should be placed on dichotomous variables rather than graded variables. Some physical signs, like clumping finger, represents a continuum from obviously normal to obviously abnormal. We name them non-specific. Recognition of those physical findings which have a high degree of inter-observer variability is important. Good examples that include detection of moderate or small amount of ascitic fluid and detection of diaphragmatic movements by percussion. These findings should be emphasized in favor of those with better reproducibility. It is beneficial to use body symmetry to advantage. Difference auscultated in breath sounds between similar area, and right and left lung are far more clinically important than an overall decrease in a breath sound. Okay, and quickly about instrumental and laboratory methods for evaluating of patient status. Lab test. Laboratory tests include a range of blood and urine tests. Blood work may include testing for genetics like inherited disorders or to determine the amount of oxygen in the blood. Urine test may be performed to check blood chemicals, bacteria, and cells for infection and other abnormalities. Main types, it is urine tests, blood test, and tumor markers. Urine tests. It is a laboratory examination of urine with various cells and chemicals such as red blood cells, white blood cells, infection, infections, excessive protein, urinalysis, break down the components of urine to check the presence of drugs, blood protein, and other substances. Blood in the urine, we name it hematuria, may be result of benign, non-cancerous condition, but it also indicate an infection or other problem. High levels of protein in the urine, which name proteinuria, may indicate a kidney or cardiovascular problem. Sorry, I need a minute. Sorry, one more time. Let's continue. Urinalysis breaks down the components of urine to check the presence of drugs, blood, protein, and other substances. Blood in the urine, hematuria, may be non-cancerous but also indicate an infection and other problems. High level of protein in the urine, which we named proteinuria, may indicate a kidney or cardiovascular problem. Blood test. They are often used to check cell count, measure various blood chemistries and markers of inflammation and genetics. Types of blood test. It is a huge number of different tests. You can see it in a laboratory lists. Let's name the main of them. It is anti-nuclear antibodies, blood chemistry study, blood lipid profile, brain natriuretic peptide or BNP testing, complement, complete blood count, creatinine, C-reactive protein, erythrocyte sedimentation rate, fecal occult blood test, genetic studies, hematocrit, liver function test, peripheral blood smear, rheumatoid factor, sedimentation rate, and more another test. All of them we will meet during learning of different system and disorders. Tumor markers. There are substances either released by cancer cells into the blood or urine, or substances created by the body in response to cancer cells. Tumor markers are substances either released by cancer cells into the blood or urine, or substances created by the body in response to cancer cells. Tumor markers are used to evaluate how well the patients have responded to treatment and check for the tumor recurrence. Research is currently being conducted on the role of tumor markers in detection, diagnosis, and treatment of cancers. According to National Cancer Institute, tumor markers are useful to identifying potential problems, but they must be used with other tests for the following reasons. People with benign condition may also have elevated levels of these substances in their blood. Not every person with a tumor has tumor markers. Some tumor markers are not specific of any type of tumor. Instrumental methods of diagnostic are widely used to more accurately determine pathological changes in the body and conduct an early diagnosis. This allows timely and maximum effective therapy and predict the course of the disease. What instrumental test we can use? It is endoscopy, biopsy, cytological analysis, functional methods, electrocardiography, spirography, pneumotachography, rentgenologic or X-ray methods. It can be divided on rentgenoscopy or X-ray or rentgenography, X-ray study. It can be tomography and ultrasonic methods. It is the main of them. And I have for you a self-control questions. What's the difference between symptom and syndrome? It was in definition. Who don't remember, please return to the start of this lecture. What is the meaning of disease? Examination methods and their diagnostic value. Structure and types of diagnosis, and what is the diagnostic value of interviewing patient. And your questions. If you have questions, if you have comments, if you have some difficult moments, in preparing to practical classes, you always can write it first of all in the comments under YouTube video on YouTube. And the best place of our discussion, it is our Facebook page. Please add to Facebook page Propaedeutics of Internal Medicine and Physical Rehabilitation Department. It is closed. It's just for students and for teachers. And if you have questions, if you have any recommendations, you can write here and there. We always glad to the waiting for the discussion, waiting for your feedback to your questions, and we'll be glad to any information for you. For today, that's all. Goodbye.